Welcome to the ICD-10 workshop.
I wanted to introduce myself to those of you who are brand new to joining us today. I am Kelly Whittle. I'm the owner of Whittle Advisors, and I do ICD-10 transition planning, not only for hospital systems, but for clinics and physician practices. Welcome to workshop number 2. Just by show of hands, how many of you participated in the first workshop? Excellent. Welcome back, and welcome to those that are new to the workshop series. There will be 4 workshops in the series. We started the first in very late October, October 23rd to be exact, where we talked about some baseline strategies for building and preparing for the transition to ICD-10. Today we're going to talk about vendor assessments and process remediation. I do have an agenda slide for you. Today I've brought a workshop number 1 recap. In addition to that, I will review the polling process. I hope you enjoyed the polling activity from workshop 1. We've brought it back. We think it's a great interactive way to get some instant feedback, some visual clues on how we're doing as a community. As I mentioned, we'll talk about vendor assessments and technology assessments and upgrades. We'll talk about process remediation. I do have some tasks and tools for you. And then at the end, we'll take a look at what those community polling results are telling us. We'll do that through the glass beads. And then as a group, we would like to do some next steps. We'd really like to get your feedback. We'd like to hear what you're struggling with at a local level. I know last time we ran a little long. Today we've pared back our presentation to give us this opportunity to dialogue at the end of our session. So if you can stay for a few moments when we wrap up, we'd love to do some interactive discussion. Great. When we think about doing a vendor assessment and understanding what changes are going to be occurring in our work environments, we want to include clearinghouses, our technology vendors, our coding and billing partners. And today I've given you a handout called a vendor questionnaire. And I do want to spend some time looking at the vendor questionnaire and providing you some background information. Now, has anybody participating today reviewed a vendor questionnaire in the past, or are you already using a vendor questionnaire? Okay. These are really great in just giving you a layout of the types of information you'll want to gather from your vendors so that you can begin to prepare appropriately for your own transition. Some of the things to consider, when will the software be available? Many vendors had positioned themselves to have software out in late 2013. Some aren't making those dates. For example, if you're working with NextGen or eClinicalWorks, it's likely that you'll see a software upgrade in the next 4 months, or the availability of software to upgrade in the next 4 months. Anybody here using NextGen? NextGen is not a simple system, as you know, that you work with it daily. You're very well aware. It takes 2 upgrades in NextGen to become ICD-10 compliant. It takes a KBM update, which is yet to be released. And that's the front skin. That's what you interact with. That's how it looks on the screen. That's how you interact with it. That's not due out until either late this year or early next year. Then comes the process of the build. Can you just implement it immediately, or do you need to think strategically about when it gets updated? All of these questions can't be answered until you understand exactly what's changing in that skin or that user interface. For example, it'll be really important to understand, will the new software allow me to capture ICD-9s prior to go live and then ICD-10s after October 1, 2014? Could I potentially capture both I-9s and I-10s and go through a period of dual coding where I'm capturing I-9s for billing and I-10s for analytics? If it doesn't allow you to do that, maybe you could start capturing the I-10s prior to go live in a different format so that you could complete those analytics and understand if there is a reimbursement impact. These are all decisions to help you meet the needs of the software change. So you'll see on the vendor questionnaire that I included things like when you call your vendor or your vendor representative, you'll want to know, are you providing me a fully functional compliant product and or service? It's really important that you get that fully functional compliant phrase in there. Some of them might be providing you a partial solution where you'll need to augment what your process is today in order to capture all of the documentation or detail. I hope that's not the case, but you'll be surprised. What date would the compliant product be available? That's important. Can I register to test with you? Will you be doing any testing prior to go live? It'll be important that your interfaces are functioning appropriately. If you're working with a clearinghouse or billing partner, can they access the system to do the billing in the I-10 compliant software? You have the questions here. You'll want to take these and review them and talk to your vendors as you move forward. I do want to add a few considerations. As you think about the ICD-10 changes, it's important to note that all of your offices will only be dealing with one piece of the change. You'll be dealing with the diagnosis codes. No need to be concerned about procedure codes unless you're doing inpatient billing. And I don't think that anybody's doing a split type of billing here. So today our conversation will be dedicated to ICD-10 CM codes, the diagnosis codes. Of course, the code length is potentially changing. We're moving up to a maximum of 7 digits, and so you'll want to make sure that your software can capture the entire length of the digit. Not only are you wanting to make sure that it captures the new structure of the code, but you'll want to make sure that your software allows you to choose more than one code. Many of you today might only be capturing the primary diagnosis code. As we move forward and medical necessity audits get more sophisticated, we'll want to be able to capture not only the primary diagnosis, but supporting diagnosis that help us to prove value for the charges that we have placed. Anybody here using the 1500 billing form? Today you can capture, is it 4 I-9 codes? In the I-10 version it captures 12. So this is exponentially larger. We're not sliding in 1 or 2 additional codes. We're talking about a full story of patient health and patient care. In addition to the structural changes of the ICD-10 codes and the magnitude of documentation required to support our care, you'll also want to talk with your vendors about the type of training and support they'll be giving for their I-10 products. For example, in NextGen, I understand that the user interface is going to look very different. And it's not a result simply of the ICD-10 changes, it's also being compounded by the Meaningful Use Phase 2 changes. So these 2 regulations coming together are causing quite a workflow adjustment in NextGen. I don't know exactly what eClinicalWorks or some of the other software vendors are doing. I'm most familiar with NextGen. But it's likely that your user interface will change. You'll want to have some training in how these changes are being laid out. Getting with your vendor and scheduling that training sooner rather than later will serve you well. I do understand that vendors like 3M, which is primarily a vendor supporting inpatient services, they're taking very few reservations for things like testing, vendor support, because they're booked to capacity. So if you haven't reached out to your vendors yet, you'll want to do that as soon as possible. You wouldn't want to receive training as late as September. You'll put yourself at risk for being prepared on go live. You'll want to ask your vendors about any hardware or other upgrades. For example, if their new user interface requires a split screen to use it very efficiently, do you need new monitors or additional hardware in your offices to be able to use the systems? Something you might want to talk to them about is historical data. Are you doing any analytics today? If you're doing a lot of reporting and business analytics, how will you marry the I-9 data with the I-10 data? Most organizations are doing this through some type of crosswalk. either through a GEMS mapping or other equivalency mapping. If that's important to you, that you be able to sustain reporting across the trend breaks, you'll want to understand exactly how that mapping is taking place. If the software is doing it for you, if there's some type of embedded translation map, it's important to understand what it is. We know that going from I-9 to I-10, there's no one-to-one match. You're likely to end up with a one-to-many match, and that can make your reporting look really different. You'll want to make sure you capture all the potential I-10 codes that align with your existing I-9s in order to be able to draw conclusions from your reports. How many of you are prepared to do testing with your vendors, whether it's coding, software vendors, data transition, clearinghouses? Testing has become a really interesting topic in the industry in the last 5 weeks or 6 weeks with the rollout of healthcare.gov, where they claim that the failure of the system came because of a lack of thorough testing. CMS has now stepped back. CMS had the thought that they would not test with individual providers in sending the Medicare claims. They weren't going to take them in. They weren't going to provide feedback to the provider environment. They just didn't have the bandwidth to do that. But now that we've had such a high visibility failure on the part of healthcare.gov, they've taken a second look at that, and now they're considering some testing periods. It's very interesting that those testing periods have been scheduled for the second week in March, when we know that most of our software vendors will not have out their compliant, somebody knows already, it won't have out the compliant software until sometime in late March or early April. And so there seems to be an industry confusion happening. We'll be testing before we have the software, but we need to do the testing in order to know if we'll be ready for October. If your software doesn't need to be upgraded, consider testing with CMS. It would be a good experience for your staff. It would be great comfort to know that your claims transfer and that you're able to receive pay. For those of you who are determining all of these details about your software systems, your clearinghouses and billing systems, keep in mind those testing periods. If you find that you are unable, due to delivery or build time or implementation time, unable to test with CMS, that's okay. There are other potential payers to test with. You can certainly test with clearinghouses. You could consider hiring a company to help you with the testing. They would act as an intermediary, not exactly testing with a payer type experience, but they could tell you if your claims are being transferred successfully. And so these are some solutions and options. I know Blue Cross Blue Shield of Michigan has been very active in the testing arena. They have been testing for more than 18 months. They're hitting the big players. They hit the Trinity Health System about a year ago. I believe we're doing some testing, coding testing with them from a Munson perspective. They're doing testing in all kinds of phases. And so if your practice is too small to do it on your own, you might want to meet up with some other practices and participate in the testing process. Their website also contains very good information on how to prepare for testing and when their testing opportunities, open enrollment for testing, will happen in the next 6 months. I'm not sure about Priority. I know Priority is your other big payer in this area. I don't know if they're doing testing. Their website might give you some insight there. Have I missed a big payer other than state Medicaid? State Medicaids across the country typically aren't in the cutting edge of preparation. They tend to lag behind. The state agencies tend to struggle. If you were part of the 50-10 transition, you'll know this very well. They were some of the last prepared entities in our industry. So I'm not sure that I would look to state Medicaid to do a good, thorough testing. I haven't heard that they're even offering testing with provider partners. In speaking to your vendors, I would absolutely start with the rep that I'm most familiar with. And then I would begin to ask the questions that are outlined. And as long as you're getting solid answers. You know, if they're saying on April 15th, we're going to have you up and running, as long as you're getting feedback that is very specific, then I would move forward with those plans. If you get ambiguity, I don't know, let me check on this, that's something you'll want to then either take to a higher level or continue the conversation with. Very often, vendors are unable to give you exact specifics. If you can get a reservation for either training, software delivery, or testing, that tends to move them along. It gets you in the queue, so to speak, of direct support, and that'll be really important. Please don't stop with ambiguous answers. It won't serve you well, and it's not likely to actually get you into the process of being delivered goods, services, or support. How many of you are really comfortable with the transition, the software transition? Is this something that you're living and breathing and you're really adept at technology, or does this give you a little bit of concern? Concern? Yeah, from a program management perspective, it gives me concern as well. Having come from Trinity with such a large number of systems in play, they have over 407 systems at Trinity to upgrade. Here at Munson, we have 43. But even 43 is a huge amount of technology to be upgraded all in a short window of time. And typically we don't have, and when I say we, I'm talking about the industry, we don't have enough technology resources to just throw at projects willy-nilly. We tend to be spread very thin. And so 43 systems is an incredible number. Each of you are likely to be working with one vendor or potentially two vendors, depending on your specialties and or coding and billing arrangements. But still, I know your practices are not flush with resources that you can have dedicated staff just working on technology.
What motivation do the insurance companies have for updating their, they're being asked to spend a lot of money? If they aren't ready, they get to keep their money and not pay out their money for claims, which is beneficial to them. Is there any sort of law or motivation for them to comply by October 14th?
Well, certainly they're the other half of the law. All HIPAA-covered entities have to comply. So our payers are really incentivized to start early and to be as transparent as payers are in exactly how they're going to pay out. You might say there's an opportunity for them to keep some of their money if they're prepared in advance. For example, there's not one dedicated crosswalk. I hope this isn't new news to you, but there isn't one dedicated crosswalk for I-9s to I-10s. There's the GEMS version of the crosswalk, but CMS will tell you that that's not the standard or the one crosswalk that has to be used. There's some art to crosswalking the I-9s to I-10s. And so sometimes we are hearing that payers like Blue Cross Blue Shield of Michigan, they've created their own crosswalk. And while that might not seem like a big deal, when they're grouped into DRGs, we start to see shifts in the payment amounts depending on where those crosswalked codes land in the new payment structure. So it's likely that the DRG shift for CMS is going to look a little different than the DRG shift for Blue Cross Blue Shield of Michigan. The Blue Cross Blue Shield crosswalk is available. I don't know for this group if it's so important for you to take a look at it because you're being paid by CPTs. And the CPT code structure will not change this year. It's important that as we go live in October, that you continue to monitor what's happening with the CPTs. I do hear a lot of rumblings in the industry that it won't change prior to go live, but about a year later, they're looking for an adjustment to the CPT codes. So it's not a problem today. Where you're likely to have your biggest impact is improving medical necessity and seeing an increase in disputed claims. And we certainly will talk about that, I think, in a future a workshop. I think it's workshop number 3. We added that to the agenda, medical necessity. Good. Other questions? Okay. How many are working with coding partners? Do you outsource your coding? You'll want to ask your coding partners what their training is, what the level of training is. It's better for them to do something that is certified by a national organization like an AHIMA certification to prepare for ICD-10. You'll want to understand, excuse me, you'll want to understand if they can help you do any of those analytics that I mentioned. And if they will, how are they going to align the I-9s with the I-10s? Could they do some of that forecasting for you? For example, on the recap video, I talked about doing some financial modeling. Can they help you with that? Can they tell you, based on your I-9 payment structure today, this is what you're likely to see in ICD-10? If you have a 10% productivity hit, how much money is that on an annual basis? If it's 20% or 30%. And those numbers, while they make my stomach hurt a little, they're not unheard of. I hear things in the industry that are projections to be much bigger than a productivity hit of 10, 20, or 30%. Certainly on the inpatient side, we did some piloting at Trinity. We saw almost a 100% coder productivity hit in the first 60 days of using ICD-10. That was huge. On the outpatient side, both in clinics and physician practices, we saw about a 40% hit to productivity. That's for coders. That's not physicians using an EHR picking a code. They move pretty quickly, whether in I-9 or I-10. But when a coder is sent in to read the charts, they're finding a huge decrease in their productivity. The good news is that the productivity hit lessens over time, meaning that education is so very vital. The more prepared they are from an education and practice perspective, the quicker you'll overcome the productivity hit. In the physician practice space, we're expecting a 25% coder productivity hit. If that's the case, how much cash on hand do you need? You'll want to consider all of these strategic decisions prior to go live. Billing partners. Anybody just sending out their billing? Okay, good. What types of business partners do you work with that we haven't covered here? Are there any categories that you have that we haven't touched on? How many of you are, let's see, how can I ask this? How many of you are really well aware of the processes within your practices? Show of hands. Really comfortable with how things are done. Good. Now keep your hands way up if you're really comfortable with how things are done. Now keep your hand up if you have these processes documented. The really exciting thing about our next topic, thank you, those of you who have the processes documented are one step ahead on the homework. We'll send you home today with a recommendation to think about your impacted processes. So certainly you'll want to think about where you're picking up diagnosis codes through the process and where you're picking up documentation that's related to those diagnosis codes. Would you move us forward on the next slide? Thank you. We're going to talk about process remediation today. And so certainly process remediation is understanding your current state process flows, understanding what's happening where, when, and how. It's best if you're not the only one that understands, but if the entire staff working in the practice is under the same impression of how things are done, it makes things easier to manage. In identifying those key impacts, again, we're focusing in on those diagnosis codes and the documentation that supports it. The idea here is to take your current knowledge, document it, and then use that knowledge to help you design your future state processes. And then certainly these materials would be invaluable as you begin to prepare training prior to go live. So each step of the effort that we're recommending in our workshops will help you to be prepared for a future step. Nothing is done haphazardly, nothing is busy work. Each step that we're recommending for you will lead to some improvement down the road or some value down the road. If you've never drawn a process map, we don't need to get into the exact specifics of every line and symbol. There are two that are really important. The first one is the square. The square represents an activity, and the diamond represents a decision. If you take those two symbols and you connect them with arrows, remember your arrows can be double-ended or single-ended, and you use only those three symbols that we've talked about, arrows, squares, and triangles, you've gotten all you need. Process diagramming can be very complicated. There's an entire science profession that's dedicated to it. That's certainly not what we're looking for. We just want to get the high-level activities down on paper so that you can use the information for designing your ICD-10 compliant processes and for training prior to go live. I've brought along a sample here, and most of you have seen process diagrams, I don't doubt. One of my preferable ways of using a process diagram is what's called a swim lane version. And so you start at the very top with this oval, and you end it with an oval, and you pick up the swim lanes of the audience or impacted process. And this works really well for physician practices. You have roles, and sometimes your roles are filled by the same person, so don't think bodies, think roles. So you have somebody at registration bringing patients into the organizations for care. So you could start at the top here that says registration. As they move from registration into an exam room, there's another role that you encounter. That role might be a medical assistant or a nurse who begins taking the reason for the visit, any relevant medical history. As you move from the registration to the MA or nurse, you then likely will encounter a provider in here, either as the third step or the fourth step. So as you build out these swim lanes, think about the roles that you're moving this patient from, the handoffs, one to the next. And then you'll very quickly begin to see not only where the education strategy comes into play. Remember, we're educating based on impact to role. The second thing that you'll quickly be able to see are the points of impact. Are we using an electronic medical record and supplemental forms to move our patients through our practices? If we are we capturing documentation that's required to support ICD-10, or are we capturing codes? If you're capturing those pesky I-9 codes, you have to take some type of remediative action. The 9s have to come off the forms or out of the systems, and you can either replace it with a space for clinical concepts to be typed in or handwritten in, or if you deal with a very, very small set of 9s, you might be able to translate them to the 10s and still get them to fit on the paper. Any questions about diagramming your processes? Some software that works really well, if you have access to Visio, that's obviously a professional tool. Certainly hop in and use Visio if you're familiar. If you're not, working in PowerPoint tends to be the simplest. You can add the shapes onto the slides and move them around pretty quickly. And you have great flexibility in the type of text that you add over each of the shapes. And if those two tools aren't available to you, grab a pencil and a piece of paper. It's not high tech, but it will get the job done, and you'll very quickly be able to visualize where in your process you need to make change. Okay. These are some of the at-risk processes. There will be others that you might consider doing a process flow for. The first is patient registration. The second is your orders process. When a provider writes an order, how is that transferred? Are you handing it back a paper slip to a patient? Are you transferring that electronically through interfaces? Certainly the billing area. In billing, you'll not only want to consider, have I captured enough documentation to support the bill that's being dropped, but when those disputed claims start coming back, especially very quickly after go live, what is the process for managing disputed claims? Who here, by show of hands, who here has a dedicated, well thought out disputed claims process today? Are you going after all the disputed claims dollars? Good. Yeah. For those of you who do this in a less formal manner, this is likely to be a big impact for you. Trinity has a CFO. I might have shared this last time. Larry McElroy is the CFO of the network at Trinity. He oversees over 500 physician practices plus clinics across 10 states. And Larry expects that in the first 60 days post-go live, he's going to see a 100% increase in disputed claims. He is so dedicated to this that he has mapped the standard process. And if you know anything about physician practices, they are hugely independent and the processes vary. So he's mapped a standard process. He's asking all practices to adhere to a standard process, a standard timeline of when to react to the disputed claims. Don't let them sit and gather dust, but respond to them immediately so that the payers have a second look at the claim before they age too long and you miss out on reimbursement. If these are areas of concern for you, you can certainly contact me through the website, or you can contact me through the Munson Healthcare email address. These are medical necessity and disputed claims are, if you do nothing else other than technology upgrades, you'll want to take a look at those two processes. And those are the last two on the list, medical necessity and disputed claims. Very important areas to secure your revenue going forward. We do have another poll for you. Before we move to that, any questions on process remediation? This is an introduction to process remediation. We're going to talk about it again in February. We're going to talk about some more specific details. I'll bring back a sample process flow for one of the areas. I haven't built it yet, but for one of the areas that are on the list for you to review. We'll talk about the exact points of impact. Is there a preference for what you'd like to see? Would you back us up one? Is patient registration, billing, medical necessity, disputed claims? Anybody have a preference for what you'd like to see in February? Disputed claims? That's a big one. We can bring that back. We can talk about the points of impact where you might want to make some adjustments, add some staff, maybe cross-train. Adding staff is often not an option, but certainly cross-training might help you to reduce some of the risk associated.
Can you share the guys from Trinity's with us?
I can't, but what I can do is glean the knowledge of a disputed claims process, and we can talk about the concepts. Okay, here's the homework section. Did anybody find Workshop 1 homework to be overwhelming? Pretty simple stuff. Many of you I know probably came to the first workshop and had already developed a budget, thought about strategies for education. The work plan was given to you as a high-level guide, a first step on the ladder, if you will, of preparing for ICD-10. This is an attempt to give you that next step on the ladder. So we're making a recommendation that you identify all of your business partners and vendors, create an inventory. It's often helpful if you aggregate contact information and vendor representatives so that you have a one-stop shop, so to speak, of where to go to think about your vendor activity. Also, develop a technology strategy using the guide that I've given you, the questions about what to ask your vendors, and start to track it by vendor. That vendor inventory becomes really helpful if you make notes of dates, of timelines, of costs. It's really important to talk to them about your current contract. Are the I-10 upgrades covered in your current contract? Is there a service fee? Sometimes the software doesn't cost anything, but the training or support does, and you'll want to understand exactly how much that is. Sometimes it's a per hour fee that can get pretty pricey. You'll want to understand any extraordinary circumstances coming out of your business partners and vendors. The sooner you know this, the sooner you can develop a contingency plan. For example, if for some reason your EMR is developed by a small mom and pop shop, something that's specific to a specialty or a region, and they're not going to an I-10 compliant version or a version that is compliant with meaningful use phase 2, you'll want to know that sooner or later, because then you're looking at either rolling back to a paper process or going with a different EMR. Both of those transitions would be substantial transitions. It would take months and months to prepare for that. Okay, thank you very much for your participation today.